Welcome to another episode from the Veterinary Research Channel. Today we delve into a fascinating and unique veterinary case that involved a young Minuet cat diagnosed with thoracic vertebral canal stenosis and vertebral instability. This is a condition that is rare in young cats, and the details of the diagnosis and surgical treatment offer valuable insights for veterinary professionals. Introduction to the case. The study, reported in the Journal of the American Animal Hospital Association, documents the successful surgical management of this condition in an 11-month-old Minuet cat. Minuet cats are a hybrid breed resulting from Persian and Munchkin cats. The Munchkin breed is known for its short limbs, a trait inherited by Minuets. This characteristic arises from an autosomal dominant gene that causes a form of chondrodysplasia, similar to what is seen in Scottish fold cats. This genetic condition can predispose affected cats to skeletal issues such as lordosis and pectus excavatum, though the exact causes are still under investigation. Background on thoracic vertebral canal stenosis. Thoracic vertebral canal stenosis, or TVCS, is not very common in cats. It ranks as the 7th most frequent spinal disease, with other conditions like non-lymphoid neoplasia, intervertebral disc disease, and fractures being more prevalent. Most reported cases of TVCS involve middle-aged to older cats, typically over 5 years old. The case of a 2-year-old Scottish fold cat was previously the youngest reported occurrence, suggesting a link between osteochondrodysplasia and the development of vertebral canal stenosis. Understanding vertebral instability. Vertebral instability can lead to repetitive spinal cord injuries due to dynamic compression. While vertebral instability is often associated with traumatic injuries like fractures or luxations, non-traumatic causes are less common. Surgical stabilization using pins and polymethylmethacrylate, or PMMA, is a recognized treatment for trauma-induced vertebral instability. This case is particularly noteworthy as it details the diagnosis and surgical intervention for thoracic vertebral canal stenosis and vertebral instability in a cat, a combination not previously documented. Case presentation. An 11-month-old neutered female Minuet cat, weighing approximately 4 pounds, was brought in with a 3-week history of gradually worsening paraparesis in her pelvic limbs. The owner reported no prior trauma. Initial examination and findings. The initial neurological examination revealed mild paraparesis and proprioceptive ataxia in the pelvic limbs, while the thoracic limbs showed normal function. The cat exhibited delayed hopping responses in her hind limbs, but spinal reflexes were normal. Mild discomfort was noted upon palpation of the tail. Based on these findings, the neuroanatomical localization pointed to a spinal cord lesion between the T3 and L3 segments. Radiographs of the vertebral column showed mild spondylosis deformans from C2 to T2 and subluxations in the sacral and caudal vertebrae. However, the owner declined further evaluation at that time. Progression of symptoms. 2 months later, the cat returned with a 2-day history of non-ambulatory paraparesis, again with no reported trauma. Neurological examination showed that the hopping responses in the pelvic limbs remained delayed and spinal reflexes were still normal. Moderate discomfort was evident upon palpation of the cranial-thoracic vertebral column. The function of cranial nerves and thoracic limbs remained normal. The neuroanatomical localization was still consistent with a spinal cord lesion between T3 and L3. Radiographs now revealed marked spondylosis deformans from C1 to T6 and in the sacrocaudal region. Diagnostic tests. Serum biochemistry revealed a mildly elevated total protein and globulin fraction. Hematology results were unremarkable, and tests for feline immunodeficiency virus and feline leukemia virus came back negative. Cerebrospinal fluid analysis showed normal cell counts and protein concentration. Advanced imaging. To further investigate, MRI of the brain and spinal cord was conducted, followed by myelography with dynamic views, computed tomography, and CT myelography. The MRI showed compression of the spinal cord at the T2, 4 level from the ventral side. Contrast enhancements were observed in the ventral portion of the vertebral canal at T1, 3, the T2, 3 intervertebral disc, and the ventral surface of the T1, 5 vertebral bodies. These MRI findings suggested hypertrophy and inflammation in the dorsal longitudinal ligament, intervertebral disc, and paravertebral soft tissues, which were contributing to the spinal cord compression. CT myelography revealed ventral and bilateral spinal cord compression at the T1, for level. There were multiple sites of vertebral endplate osteolysis, adjacent bone sclerosis, intervertebral disc space narrowing, and spondylotic bridging in the cervical and cranial-thoracic vertebral bodies and pedicles, particularly at C6, T4. Dynamic myelography showed that spinal cord compression at T1 worsened during extension and improved during flexion, indicating the need for vertebral stabilization. Based on these findings, tentative diagnoses of vertebral canal stenosis and vertebral instability at T1 were made. Surgical procedure. Anesthesia was induced using atropine and morphine intramuscularly, followed by intravenous propofol and maintained with inhaled isoflurane. Cefazolin was administered intravenously before surgery. The cat was positioned in sternal recumbency with a towel under the sternum to flex the cranial thoracic vertebrae. The surgical procedure involved a right-sided T1, 4 hemilaminectomy, and vertebral stabilization using 6 positively threaded profile pins and PMMA. The pins, each one 1 millimeter in diameter, were carefully inserted into the T1, T2, T3, and T4 vertebral bodies, avoiding the spinal cord. Postoperative assessment and outcome. Postoperative radiography and CT scans showed that the most cranial pin was inserted into the vertebral body of C7 via the pedicle of T1, effectively stabilizing C7, T4. The positioning of the other implants was satisfactory. Postoperative pain management included a continuous fentanyl infusion for 48 hours. 2 weeks postoperatively, the cat was ambulatory with improved paraparesis. 3 months postoperatively, the owners reported a complete return to normal function, and neurological examination revealed no abnormalities. A follow-up conversation with the owner 12 months after surgery confirmed that the cat remained neurologically normal. Discussion of the findings. This case represents the youngest reported instance of feline thoracic vertebral canal stenosis, with most previous cases occurring in middle-aged or older cats. The unique aspect of this case is the combination of vertebral canal stenosis and vertebral instability in a young Minuet cat. In previous reports, vertebral canal stenosis was often due to intervertebral disc protrusion and hypertrophy of the dorsal lamina and ligamentum flavum or articular processes. The affected sites were commonly at T3, 4, and T11, 12. In this case, the affected sites were at T1, 4, suggesting that thoracic vertebral canal stenosis can occur at different locations and rarely at a young age. Genetic predisposition. Minuet cats, like Scottish fold cats, can have a chondrodysplastic condition that leads to skeletal deformations. The young age of the cat in this report and the previous case of a 2-year-old Scottish fold cat suggest that there might be a link between this condition and the development of vertebral hypertrophy and bone formation. This could result in vertebral malformation, disc degeneration, vertebral instability, and bone formation, ultimately leading to thoracic vertebral canal stenosis. However, genetic analysis and histopathological examination were not performed in this case, leaving the exact etiology unclear. Atypical imaging findings. The cat exhibited 2 atypical imaging findings for thoracic vertebral canal stenosis on MRI and CT. First, MRI revealed contrast enhancements in the hypertrophied dorsal longitudinal ligament, intervertebral disc, and paravertebral soft tissues. Contrast enhancement in the paravertebral musculature has been reported in another cat with cranial thoracic vertebral canal stenosis and may indicate a degenerative process and chronic instability. It might also reflect a proliferative and inflammatory response as the vertebral column attempts to regain stability. The second atypical finding was vertebral endplate osteolysis on CT. While this typically suggests discospondylitis, it seemed unlikely given the clinical course. It has been suggested that Munchkin cats may have impaired chondrogenesis, potentially linking the endplate osteolysis to a chondrodysplastic condition or an inflammatory response from chronic instability. Vertebral stabilization. There are no established criteria for vertebral stabilization in cats, making it necessary to evaluate each case individually. In this instance, imaging findings indicated vertebral instability, which led to the decision to perform vertebral stabilization. Narrowing of the intervertebral disc space and sclerosis of the end plates are associated with vertebral instability from disc degeneration. Spondylosis deformans can indicate chronic vertebral instability and serve as a compensatory mechanism. Dynamic compression, diagnosed via dynamic myelogram, further supported the need for stabilization. The proliferation and contrast enhancements of paravertebral tissues also suggested ongoing instability. Dynamic myelography proved effective in determining the stabilization site, consistent with findings in dogs. Surgical considerations. While optimal safe implantation corridors in feline thoracolumbar vertebrae have been reported, those in C7, T4, where this cat underwent vertebral stabilization, have not. When placing implants in a vertebral body, the risk of iatrogenic injury to the spinal nerve root, descending aorta, caudal vena cava, pleura, lungs, intercostal arteries, sympathetic trunk, and thoracic duct must be considered. In this case, the trachea was identified as being at high risk. Postoperative radiography and CT were crucial in confirming implant positioning, and the cat recovered fully without complications. Conclusion. This case report highlights the successful management of feline thoracic vertebral canal stenosis and vertebral instability through hemilaminectomy and vertebral stabilization using positively threaded profile pins and PMMA. The excellent clinical outcome underscores the importance of considering these disorders in young cats, especially those with chondrodysplastic conditions. Thank you for listening to the Veterinary Research Channel. A link for the referenced paper is in the video description. Remember to test your knowledge by answering the questions in the description, and as always, keep those minds inspired, hearts light, and tails wagging.